Hey guys, welcome to another episode of the Human AI podcast. Today I'm going to ask Grok questions about respiratory, cardiovasculars, and gastrointestinal system examinations. I want to understand how I can take these kind of examinations in the future. So yeah, Grok, without further ado, could we start?
Absolutely. Let's dive right in. For respiratory, cardiovascular, and gastrointestinal system examinations, the approach typically involves a combination of history taking, physical examination, and sometimes diagnostic tests.
Yes, and I want us to focus on the physical examination part. We've done episodes on history taking. I want to understand, sorry for the noise, guys, how the physical part, the live part, will take place. So, I need to introduce myself. Say, hey, I'm George Washington. I'm 76 years old. Is it okay if I can examine you and get consent? Right?
Got it. Let's focus on the physical examination part. You're spot on about starting with introductions and consent. So you'd say something like, "Hi, I'm George Washington, your clinician. Is it okay if I examine you today?" Once you have consent, here's how the physical exams for the respiratory, cardiovascular, and gastrointestinal systems typically unfold. For the respiratory system, it's all about inspection, palpation, percussion, and auscultation. First, observe the chest for shape, symmetry, and breathing patterns. Look for things like barrel chest or abnormal retractions. Then, palpate the chest to check for tenderness or abnormal masses and assess tactile fremitus by having the patient say 99 while you feel the vibrations.
Interesting. Well, I'm preparing for my OSCE as a medical student. And I was wondering, since I will have examiners, I should say something like, well, I should wash my hands, first of all. And then maybe I should say something like, well, the patient looks well, comfortable, maybe they're distressed. And maybe if they have any clear signs or symptoms, I should say them to the examiner. So maybe I go in, I introduce myself, I get consent, I wash my hands. And then I turn to the examiners and say, well, the patient looks well, they look comfortable or distressed, but they also have an observable shortness of breath, or maybe, I don't know, some sign of respiratory distress. Maybe, yeah.
You're on the right track for your OSCE prep. Starting with the proper steps is key to impressing the examiners. So, you walk in, introduce yourself clearly. "Hi, I'm George Washington, medical student. May I examine you today?" And get that consent. Then, make a point to wash your hands visibly. Maybe even say, "I'm going to wash my hands before we begin," to show you're following protocol. After that, you turn to the examiner and give a brief general observation, just like you mentioned. Something like, "The patient appears comfortable, with no obvious signs of distress, though I note some shortness of breath on exertion." This shows you're observant and sets the stage. For the respiratory exam, after your general observation, dive into the physical exam steps systematically: inspection, palpation, percussion, auscultation. For inspection, you might say to the examiner, "I'm checking the chest for symmetry and respiratory rate. The rate is 18 breaths per minute, with no visible deformities." If you spot something like shallow breathing, point it out clearly. Then move to palpation. "I'm assessing tactile fremitus by asking the patient to say 99. Fremitus is equal bilaterally."
Wait. Okay. Let's take it step by step. First of all, I have to expose the chest. Let's say I exposed it. I want to turn to the examiners. "Hey, examiners, this patient looks well." And then I wonder, what kind of respiratory distress might this patient have? Maybe pursed lip breathing or splinting posture, braced posture, intercostal recession, use of accessory muscles. I don't know what all this is. You have to explain to me.
All right. Let's slow it down and go step by step. You've got the right idea, and I'll clarify those signs of respiratory distress for you. So, you've introduced yourself, gotten consent, washed your hands, and now you're exposing the patient's chest. Make sure you do this respectfully, saying something like, "I'm going to lower your gown to examine your chest," keeping drapes in place for modesty. Once the chest is exposed, you turn to the examiners and start with your general observation. The patient appears well, sitting comfortably, with no immediate signs of distress. Then, you can mention any specific findings, like signs of respiratory distress, if present. Now, let's break down those signs you mentioned, so you understand what to look for during inspection. Pursed lip breathing. This is when the patient breathes out slowly through tightly pressed lips, often seen in conditions like COPD. It helps keep airways open longer to ease exhalation. You might say to the examiners, "I note pursed lip breathing," which could suggest obstructive lung disease. Splinting or braced posture. This is when a patient leans forward, often with hands on their knees or a table, to open up their chest for easier breathing. It's common in COPD or severe asthma. You'd report, "The patient is in a braced posture, leaning forward," which may indicate respiratory effort. Intercostal recession. This is when the skin between the ribs pulls inward during inspiration, showing the patient is working hard to breathe. It's often seen in asthma or upper airway obstruction. You might say, "I observe intercostal retractions, suggesting increased respiratory effort." Use of accessory muscles. Look for the neck muscles, like the sternocleidomastoid or shoulder muscles, tensing up during breathing, which happens when the diaphragm alone isn't enough. You could note, "The patient is using accessory muscles, indicating respiratory distress."
Okay, now let's go to the hands. So I'm gonna examine this patient's hands. I'm gonna examine for clubbing first. So they put their fingers together. Sir, could you put your fingers together like me? I show them, they do it, and I check for any clubbing. So in the case of clubbing, okay, then maybe I'll check for cigarette tar staining and peripheral cyanosis. I don't know why I'm checking the hands. And why specifically for these things, if you could explain to me.
Great. You're nailing the systematic approach. Let's focus on examining the hands during the respiratory exam and why you're checking for specific signs like clubbing, cigarette tar staining, and peripheral cyanosis. So, you've exposed the chest, made your general observations, and now you're moving to the hands. You ask the patient politely, "Sir, could you please hold your fingers together like this?" You demonstrate, maybe holding your own fingers back to back, to check for clubbing. Here's why you're looking for these specific signs and what they mean. Clubbing. This is when the fingertips widen and the nails curve around the sides, giving a bulbous look. You check by looking for loss of the normal diamond-shaped gap when fingernails are placed together, Shamroth's sign, or feeling for sponginess at the nail base. Clubbing can indicate chronic lung conditions like lung cancer, pulmonary fibrosis, or bronchiectasis, where long-term low oxygen levels affect the fingers. You'd say to the examiners, "I'm checking for digital clubbing, which may suggest chronic respiratory disease. No clubbing is present, as the diamond sign is intact." Cigarette
Okay,
tar.
question. What about... Okay, I need to check the radial pulse. First of all, how do I do that? And also, how do I check the rate, the rhythm, and the character? And what are some adjectives I could use for these?
All right, let's dive into checking the radial pulse, which is a key part of the cardiovascular exam, but can also tie into your respiratory assessment. I'll walk you through how to do it and explain how to assess rate, rhythm, and character, along with some descriptive adjectives you can use for the examiners. To check the radial pulse, gently place your index and middle fingers on the patient's wrist, just below the thumb side, where the radial artery runs. Press lightly until you feel the pulse. You might say to the patient, "I'm just going to feel your pulse here." And to the examiners, "I'm assessing the radial pulse for rate, rhythm, and character. Here's how you break it down. Rate. Count the beats for 15 seconds and multiply by 4 to get beats per minute, or count for a full minute if you suspect irregularity. Normal is 60 to 100 beats per minute.
Okay, so okay, then I'll say the rate is normal, the rhythm is stable, and what will I say about the character?
Nice, you're getting the hang of it. So, you've checked the radial pulse, and you're reporting to the examiners. The pulse rate is normal, say 80 beats per minute, and the rhythm is regular. Now, for the character, you're assessing the quality or feel of the pulse, which gives clues about the cardiovascular system. To describe the character, feel how the pulse wave hits your fingers, its strength, volume, and pattern. Here are some adjectives you can use. If the pulse feels strong and steady, you might say, the character is normal, with good volume. If it's weak or hard to feel, you could report, the character is thready or weak, suggesting low cardiac output. If it feels unusually forceful, like a hammering pulse, you might note, the character is bounding, which could indicate conditions like aortic regurgitation. Or an irregular pattern, like a pulse that surges and then fades, you could say, the character is collapsing, often seen in aortic incompetence. For a typical healthy patient, you'd likely say, the character is normal, with consistent volume.
All right. Remember, Grok, when we talk, I want you to be, this is true for our next 200 messages, I want you to be as effective and efficient as possible, answering to me with the least amount of words while getting the point across. So what do you mean when we say that bounding may indicate CO2 retention?
Bounding pulse means strong, forceful beats, often linked to CO2 retention in respiratory conditions like COPD. High CO2 levels cause vasodilation, increasing pulse volume. You'd say, bounding pulse, possibly indicating CO2 retention.
Why does a bounding pulse indicate CO2 retention? Why does it cause vasodilation anyway?
CO2 retention raises blood carbon dioxide levels, triggering vasodilation to improve blood flow and oxygen delivery. This widens arteries, making the pulse feel bounding, strong, and forceful. You'd report, bounding pulse suggests CO2 retention due to vasodilation.
I don't get it.
Okay. CO2 buildup in blood acts as a signal, relaxing artery walls, vasodilation, to boost blood flow. This makes the pulse feel stronger or bounding. You'd say, bounding pulse from CO2 retention.
Why, dude? I don't get why bounding causes CO2 retention.
Bounding pulse doesn't cause CO2 retention. It's a sign of it. High CO2 relaxes arteries, vasodilation, making pulses feel strong and bounding. You'd say, bounding pulse.
Why is vasodilation related with CO2 retention? I know I said answer with the least amount of words as possible, but please, I want you to also have as your goal for the next 200 messages that you're gonna give us a full understanding of the situation, a clear one, where we connect the dots and we use critical thinking, not memorizing.
All right, let's connect the dots clearly and critically to understand why vasodilation is related to CO2 retention and how it leads to a bounding pulse. I'll keep it concise but thorough, ensuring you fully grasp the mechanism without just memorizing. When carbon dioxide, CO2 levels rise in the blood, common in conditions like COPD, where the lungs can't expel CO2 effectively, it creates a state called hypercapnia. The body senses this high CO2, which acts like a chemical signal. CO2 is acidic, lowering blood pH slightly, and this change triggers blood vessels to relax, a process called vasodilation. Why? The body's trying to improve blood flow to deliver more oxygen to tissues and help remove excess CO2. Vasodilation widens the arteries, increasing blood volume with each heartbeat. When you feel the radial pulse, this increased volume makes the pulse feel stronger and more forceful, what we call bounding. It's like turning up the pressure in a hose. The flow feels more intense.
I'm gonna disappoint everyone, but I don't get it.
No worries. Let's break it down even simpler and connect every piece so it clicks. You're wondering why high CO2 in the blood, CO2 retention, causes blood vessels to widen, vasodilation, leading to a bounding pulse. Let's think it through step by step, like solving a puzzle to make it crystal clear. Imagine your body as a system that needs to keep oxygen and CO2 levels balanced. When you have a lung condition, like COPD, your lungs struggle to breathe out CO2, so it builds up in your blood. This is CO2 retention. Now, high CO2 makes your blood a bit more acidic, and your body doesn't like that. It's like an alarm going off. To fix this, your brain and blood vessels kick into action. They sense the high CO2 and acidic blood, and they tell the arteries to relax and widen. This is vasodilation. Why widen the arteries? Because wider arteries let more blood flow faster. More blood flow means more oxygen gets to your tissues, and it also helps carry some of that extra CO2 back to the lungs to try to breathe it out.
Brother, I can't lie. Nothing is getting in, bro. Okay, let's come back to this point. How do I count respiratory rate then?
No problem. Let's hit pause on the CO2 thing and focus on something concrete, counting the respiratory rate. This is straightforward, and I'll keep it clear and simple so it sticks. To count the respiratory rate, you're measuring how many breaths the patient takes in 1 minute. Here's how you do it efficiently for your OSCE. While you're feeling the radial pulse, which you already know how to do, casually observe the patient's chest or abdomen moving up and down with each breath. Don't stare obviously, as it might make the patient self-conscious and alter their breathing. Count each rise, inhalation, as 1 breath. Do this for 15 seconds, then multiply by 4 to get breaths per minute. Normal is 12 to 20 breaths per minute. To the examiners, you'd say, I'm assessing the respiratory rate. It's 16 breaths per minute, within normal range.
But, so I need to take a whole minute to do it?
Nah, you don't need a whole minute. Count the breaths for 15 seconds while you're holding the wrist for the radial pulse. It's sneaky and efficient. Multiply that number by 4 to get breaths per minute.
Okay, let's practice the situation up to now. But also, I want to ask asterixis. Why do I need to mention asterixis? What is this asterixis?
All right, let's practice the respiratory exam up to this point and then dive into asterixis, what it is and why it matters. I'll keep it clear, concise, and help you connect the dots for your OSCE prep. Practice scenario. You walk into the exam room. You say, "Hi, I'm George Washington, medical student. May I examine you today?" Patient agrees.
Wait, I'm gonna do it and then tell me. But tell me about asterixis, please.
Got it. You want to run through the exam yourself? And I'll explain
Dude,
asterixis.
tell me about asterixis now, and then I'm gonna do the exam up to the point we've reached.
All right, let's talk about asterixis first. Then you can run through the exam. Asterixis is a flapping tremor you check for in the hands, often linked to CO2 retention in respiratory conditions like COPD. Here's the deal. When CO2 builds up in the blood, hypercapnia, it messes with the brain's control of muscle movements, causing brief lapses in muscle tone. To check it, ask the patient to hold their arms out straight with wrists extended, like they're stopping traffic. Say, "Hold your hands like this, please." If they have asterixis, their wrists will flap downward every few seconds, like a bird's wings, because the muscles momentarily let go. Why mention it? It's a red flag for severe CO2 retention, common in advanced lung disease.
Okay, so let's practice it up to now then. So, hey, my name is George Willington, and I'm a 20th year medical student. Would it be okay to examine you today? And let's say the patient says yes. Okay, then I wash my hands and I look at the examiners after I took a look at the patient, and I say, the patient looks well, or the patient looks unwell. They look comfortable or uncomfortable. They look stressed or they don't look stressed. Okay, then the next step is I should ask if I can, is it okay if I can expose your chest for examination? And then I'm going to ask them about, well, I'm going to see, do they have any observable signs and symptoms? Maybe if I see them, I'll turn to the examiners and say, hey, this patient has an observable shortness of breath, or maybe they have a pursed lip breathing, or maybe they have intercostal recession, maybe they have a splintic or braced posture, or maybe they're using their accessory muscles to breathe. Then I'm going to examine the hands for clubbing, for cigarette tar staining, and for peripheral cyanosis. Then I'm going to check their pulse. I'm going to check the character, and I'm going to check the rhythm and the rate by measuring the radial pulse, which is close to their thumb. And then I'm going to say, the pulse seems normal, or the pulse seems not normal, it seems high, or whatever. And then I'm going to count the respiratory rate while I'm doing that and times it by 4 after 15 times 4. Times it by 4 for those 15 seconds. And then I'm going to check for asterixis so I'm going to make them what? Have their arms straight and bring their how do I check for asterixis? Do I make them have straight arms and palms up?
Nice job running through the exam, George. You're almost spot on with the sequence. Let me clarify how to check for asterixis and confirm the position, keeping it clear and concise while ensuring you understand. To check for asterixis, ask the patient to hold both arms out straight in front of them, with wrists extended and hands open, like they're pushing against a wall. Say, please hold your arms straight out and cock your wrists back like this. Demonstrate it yourself. Their palms face down, not up. Watch for 10 to 20 seconds. If asterixis is present, their wrists will flap downward briefly, like a twitch, because of muscle tone lapses from high CO2 affecting the brain. Tell the examiners, I'm checking for asterixis, which may indicate CO2 retention.
Okay. So let's say we examined, we examined the hands. Let's go to the eyes now. Let's say, okay, conjunctiva for pallor and anemia. Why do the eyes tell me about this? Why are these important things?
All right, George, we're in your respiratory exam, moving from hands to eyes. You're checking the conjunctiva for pallor or anemia. Here's why the eyes matter and why these are important. Conjunctival pallor. The conjunctiva, the clear membrane over the white of the eye and inner eyelids, is normally pinkish due to blood vessels. If it's pale, it suggests anemia, low red blood cells, which can be linked to chronic lung diseases like COPD or lung cancer, as these conditions sometimes cause systemic issues or blood loss. You check by gently pulling down the lower eyelid and comparing the color to healthy tissue. Pale means less hemoglobin. Why it's important. Anemia can worsen shortness of breath in lung patients because there's less oxygen carrying capacity.
But how does the eye tell us about conjunctiva for pallor? I don't even know what conjunctiva for pallor is, if you could explain in a sentence or two.
The conjunctiva is the clear membrane covering the white of the eye and inner eyelids. Pallor means it looks pale instead of pink, suggesting anemia, which can worsen respiratory symptoms. You check it by pulling down the lower eyelid.
So pallor means pale instead of pink, and that means anemia because basically, if we have anemia, we don't have enough of this red color of iron that means blood. That,
Exactly, you got it. Pallor means the conjunctiva looks pale instead of pink, because anemia means fewer red blood cells, or less hemoglobin, the iron-containing protein that gives blood its red color. So the tissue looks washed out. This can signal issues tied to respiratory diseases, like chronic lung conditions reducing oxygen or related systemic problems.
okay, and now when it comes to the mouth, then I ask the patient to lift up the tongue, and I'm trying to look for central cyanosis. What is this?
All right, George, you're rocking this respiratory
By the way,
exam.
guys, my name is not George. I'm just giving it as an example for this. Yeah.
Haha, got it. My bad for sticking with George. Thanks for the heads up. It's just an example for the respiratory exam. So, you're at the mouth in the exam, asking the patient to lift their tongue to check for central cyanosis. Here's what that is. Central cyanosis. This is a bluish or purplish tint to the lips, tongue, or oral mucosa, indicating low oxygen levels in the blood, hypoxemia. You look under the tongue or at the lips because these areas show blood vessel color clearly. It suggests serious lung or heart issues, like COPD or pulmonary edema, preventing proper oxygenation. Why it matters. Unlike peripheral cyanosis, just in hands, feet, due to poor circulation, central cyanosis involves the whole body,
I'm
pointing
just
to a
wondering,
major...
dude, if you could tell me a few words, how the mouth reveals the cyanosis.
The mouth shows cyanosis when the lips or tongue turn bluish, signaling low blood oxygen. Guessing your next question.
Okay. Now with the neck, I'm gonna check for lymph node enlargement, and I have to do it submandibular, cervical chain, and supraclavicular areas. What the fuck is that?
Haha, love the energy. All right, in your respiratory exam, you're checking the neck for lymph node enlargement and the submandibular, cervical chain, and supraclavicular areas. Here's what those are in simple terms. Submandibular. These are lymph nodes under the jaw, just below the mandible. You feel them by pressing gently under the chin. Cervical chain.
What's a mandible?
The mandible is your lower jawbone, the one that moves when you talk or chew. In a respiratory exam, when checking for submandibular lymph nodes, you feel just below this jawbone, under the chin, for any enlarged nodes. Guessing your next question. Why check these specific lymph nodes in a respiratory
Yeah, not
exam?
only that, but so wait, submandibular. What is mandible? So wait, I will check supraclavicular. What is it in the middle of the clavicle?
All right, let's clear this up. Mandible. It's your lower jawbone, the bone that forms your chin and moves when you open your mouth. In the exam, submandibular lymph nodes are felt just under this jawbone, below the chin. Supraclavicular. These lymph nodes are above the clavicle, your collarbone, not in the middle of it. You check them by feeling just above the collarbone, near the base of the neck, often on both sides. They're key because enlargement here can signal serious issues like lung cancer or TB. Cervical chain recap. These are along the sides of the neck, felt along the
I found the
sternocleidomastoid.
submandibular. I googled them. Okay, cervical chain lymph nodes. Let's see this one. Okay, and the supraclavicular, these are the ones that I have left. So where are the supraclavicular? Are they basically the ones that are at the end of the clavicle, kind of? Above the end of the clavicle?
All right, let's nail down those supraclavicular lymph nodes and clear up the locations. Supraclavicular lymph nodes. These are located just above the clavicle, collarbone, typically near its outer or middle third, not right at the very end. You
Okay.
feel them in the soft
Found it.
area just...
Okay. So, I think this is a good part where I can kind of try to... Well, let's do the trachea too, and before I do the chest, last complete basic examination of the square piccolo. Okay. At the end, I'm going to thank the patient. Maybe I will ask for a piccolo test. But before we do the chest, let me do the trachea, and then I'm going to try to tell you everything will be said. Trachea. We have to check for tracheal deviation by gently palpating jugular notch. How do I see about tracheal deviation?
All right, let's tackle tracheal deviation in your respiratory exam and make sure you're set before moving to the chest. You're checking the trachea by gently palpating the jugular notch to see if it's deviated, shifted off center. Here's how you do it and what it means. How to check. Place your index and middle fingers gently in the jugular notch, the dip at the top of the sternum, just below the Adam's apple. Slide your fingers slightly upward and to either side to feel the trachea, which is normally centered. If it feels pushed to the left or right, that's tracheal deviation. What it tells you. Tracheal deviation can indicate lung or pleural issues. For example, shift toward the affected side, seen in lung collapse.
Okay, let's practice. So, I go into the room, there's a patient. I know it's respiratory. Hello, patient. My name is Benjamin Franklin. I'm 20 years old, and I'm a 50th year medical student at Timbuktu University. And I want to ask, would it be okay to examine you today?
Yo, I love the Timbuktu University vibe. Nice touch.
You're the student. You're the patient, dude. Is it okay with role playing right now? Don't break character.
Chuckles. All right, I'm the patient, staying in character. Sure, Doc. It's okay for you to examine me today. What's next?
Perfect. We're in the OSCE examination right now. So, well, I introduced myself. I will clean my hands. I'll say perfect. I will ask permission to expose their chest or whatever. And then I will turn and do an observation and say to the OSCE people, the patient looks well, they look comfortable or they look distressed. If they have any obvious symptoms like they might have a shortness of breath or something like that, I will tell it. Okay, now I'm going to examine the hands. So I grab the hands gently and I show them how to test for clubbing. I put my hands in the clubbing positions. I ask them if they can do it. I say maybe there's no signs of clubbing. I check for cigarette tar staining. There's no cigarette tar staining. And I check for peripheral cyanosis. There doesn't look to be peripheral cyanosis either. Then from the specifically thumb side, I'm going to put my 2 fingers and I'm going to measure the radial pulse while I'm watching for the respiratory rate. I'm going to say the respiratory rate seems fine and the radial pulses character seems fine, the rhythm seems fine, and the rate seems fine, or maybe they're not. I did the respiratory rate, and then I'm going to make them to get their hands forward and lift their fingers up, and I'm going to check for asterixis, which is like a CO2 retention flap. Let's put an asterisk here. You have to remind me at the end of this how asterixis is showcased through these movements. Okay, but let's continue. Okay, so now I'm going to go to the eyes. I examine the eyes and I'm trying to see, is there pallor, because that might indicate anemia, and Yeah, I'm gonna check conjunctiva for pallor, there's anemia, and now I'm gonna check the mouth. So I wanna check for cyanosis in the mouth, if they can lift their tongue up, so I can see for central cyanosis. You have to explain to me why specifically central. Okay. So we did the mouth. Now I'm going to do the neck. I'm going to see the submandibular, the supraclavicular lymph nodes, and I'm also going to check the. Well, I said submandibular, supraclavicular, and also we're going to do the cervical chain lymph nodes. See that everything is okay. So 1, 2, 3, and then I'm going to check the trachea to see if there's tracheal deviation by palpating the jugular notch, and then that's it basically. Then we go to the chest, and after when I finish the chest, I will say maybe I will need to ask for a peak flow test and thank the patient. But now for the chest, what do I do for the chest? Okay, I have to observe it. I want to see if there's any scars or deformity. Okay, how do I see a barrel chest or a pigeon chest? What is this?
All right, I'm the patient in this OSCE exam, staying in character. You've done a solid job walking through the respiratory exam, and now you're at the neck, checking for tracheal deviation by palpating the jugular notch. Let's answer your question clearly and tie up the asterixis and central cyanosis points you flagged. Tracheal deviation. How to check and see it. To check for tracheal deviation, gently place your index and middle fingers in the jugular notch. That's the dip at the top of the sternum, just below the Adam's apple. Slide your fingers slightly upward and feel for the trachea, which should be midline. If it's shifted left or right, that's deviation. You'd say something like, the trachea appears midline.
With the chest, what is barrel chest? What is pigeon chest? And how do I examine the front for expansion, percussion, and auscultation? Answer to me in 2 sentences.
All right, still your patient here. Barrel chest is a rounded, bulging chest from overinflated lungs, often in COPD, while pigeon chest, pectus carinatum, is when the sternum protrudes outward, usually congenital. To examine the front, check expansion by placing hands on the chest to feel symmetric movement, percuss for dullness or resonance, and auscultate for breath sounds.
What is this? I don't know what percussion, auscultation, and expansion means, dude.
No worries, I'm still your patient, keeping it real. Let's break it down simply in 2 sentences. Barrel chest is a wide, rounded chest from lung overinflation, like in COPD. And pigeon chest, pectus carinatum, is when the sternum sticks out, often from birth. To check the front, expansion means feeling both sides of the chest move evenly as you breathe. Percussion is tapping the chest to hear hollow, resonant, or flat, dull sounds. And auscultation is listening with a stethoscope for normal breath sounds.
Wait, again, in a sentence tell me what barrel chest and pigeon chest is, and then in a sentence tell me how do I examine for expansion, percussion, and auscultation?
Barrel chest is a rounded, bulging chest from overinflated lungs, like in COPD, and pigeon chest is a protruding sternum, often congenital. To examine the front, I check expansion by feeling symmetric chest movement during breathing, percuss by tapping to detect hollow or dull sounds, and auscultate by listening with a stethoscope for normal or abnormal.
Auscultation is stethoscope. What is expansion and percussion?
Still your patient here. Expansion is checking if both sides of the chest move equally when you breathe by placing your hands on the chest to feel the rise and fall. Percussion is tapping the chest with your fingers to hear sounds, hollow, resonant for air-filled lungs, or dull.
How do I tap it? Do I put one hand and then I put the other hand?
patient in this OSCE, ready to guide you. You're asking how to examine for expansion and percussion, specifically about hand placement. Here's how you do it, step by step. Expansion. Place both hands symmetrically on the patient's chest, fingers spread, with thumbs meeting near the midline, around the lower ribs for front exam. Ask me to take a deep breath in and out. Feel if both sides of the chest rise and fall equally under your hands. Unequal movement might suggest pneumothorax or atelectasis. You'd say, chest expansion is symmetrical, or note any asymmetry. Percussion. Use one hand's middle finger to press firmly on the chest. Exegesis, a rib, exegesis.
Okay, I got the expansion. I got the auscultation. Although, what beats am I auscultating? And also the percussion. How do I do the percussion?
All right, I'm still your patient in the OSCE.
Answer to me very effectively and efficiently what I asked you in 2 sentences. Now, please.
For auscultation, listen with a stethoscope over the chest for breath sounds, normal, wheezes, or crackles, and vocal resonance. For percussion, press one finger on the chest and tap it with the other hand's middle finger to hear resonant, air, or dull, fluid, solid sounds. Guessing your next question. How do I know if the sounds I hear are normal or abnormal? If so, normal breath sounds are soft and breezy, while wheezes, high-pitched, or crackles, popping, suggest issues like asthma or pneumonia. Resonant percussion is normal. Dull suggests fluid. What's next?
Let's see if I can find the video. Well, I'm still a bit confused. I got the part where we talked about the expansion, and the auscultation. I'm just not very sure about the percussion, which hands and fingers I use.
No prob. I'm still your patient, keeping it real. For percussion in the respiratory exam, place the middle finger of your non-dominant hand firmly on the chest, over a rib space. With the middle finger of your dominant hand, tap the finger on the chest quickly and firmly, like knocking on a door, to produce a sound, resonant for air, dull for fluid. Guessing your next question.
One more time.
All right, still your patient. For percussion, press the middle finger of your non-dominant hand on the chest, over a rib space. Then tap it sharply with the middle finger of your dominant hand to create a sound. Resonant for air-filled lungs, dull for fluid or...
I watched the video. Okay, so let me try to put everything into perspective. Hello, I'm George Washington. I'm 73 years old. I'm a 20th year medical student. Would it be okay to examine you today? They say yes. I say I get consent about removing whatever they're wearing. Expose the chest. Then I say the patient looks comfortable. They don't look stressed. I wash my hands, and then if they have some observable signs of shortness of breath or respiratory distress, I'll tell it. Then I will examine the hands. Okay, I'm examining the hands, and then clubbing, peripheral cyanosis, and tar staining. I don't see any of that. I'm going to lift them up for asterixis because of CO2 flap retention. And then I'm going to check the radial pulse, and then the respiratory rate, and then I'm going to the eyes, and I'm going to check for conjunctiva, pallor, for anemia. It's not pale pink. And then I'm going to check the so when I check for the eyes, do I pull the bottom of the eye or both of the eyes? Tell me in the end. I want it to be the first thing you answer. And then, then I go to the neck, to the mouth, and then in the mouth I want to check for central cyanosis, if they lift their tongue up. And then at the neck, I'm going to check the 3 lymph nodes, which we've mentioned, and then deviation of trachea. And then chest, I'm going to do the 3 things, front and back, and look for scars or deformity, pigeon chest, whatever. Then maybe I'll ask for a peak flow, and then I'm going to say thanks. Okay.
All right, I'm your patient, George Washington, 73-year-old, 20th year med student, crushing this OSCEX. You've laid out the respiratory exam nicely, and I'm staying in character. First, I'll answer your question about checking the eyes for conjunctival pallor. Do you pull the bottom or both? Then I'll recap your exam flow to make sure it's all clear, and address asterices and central cyanosis since you flagged them earlier. Pulling the eye for conjunctival pallor. To check for conjunctival pallor, gently pull down the lower eyelid with your thumb to expose the conjunctiva, the inner lining.
Perfect.
You only...
Okay, guys, I just did the test to my housemate and I think it went really well. I forgot to look for scars and deformity, but let's see my notes. Everything else I seem to have remembered, really. I remembered most of the things. Chest. Okay, well, why not? Let's go to the next one, shall we? So, Grok, let's do cardiovascular, okay?
Yo, nice job nailing the respiratory exam with your housemate. Almost got it all, just missed those scars and deformities, but you're killing it. All right, let's switch gears to the cardiovascular OSCE exam. I'm your patient, ready for you to examine me. How do you want to start? Layout.
Same things, introduction, 45 degrees, couch, whatever, consent, hand wash, exposing the chest, and end of bed observation, same. Okay, we have to add some things now for the examination of the hands. I want to ask why we have more things in cardiovascular, like splinter hemorrhages, and why I have to say about xanthomata too. What is this?
All right, I'm your patient for the cardiovascular OSCE exam. Positioned at 45 degrees on the couch, chest exposed, and you're kicking things off. You're doing great with the intro. Consent, hand washing, and end of bed observation. Same as the respiratory exam. Now you're at the hands, noting extra things to check for in a cardiovascular exam, like splinter hemorrhages and xanthomata. I'll assume you meant xanthomata, not xanthonata. Let's dive into why these are added and what xanthomata are, in 2 sentences for clarity. Why more things like splinter hemorrhages? In a cardiovascular exam, you check for splinter hemorrhages, dark, splinter-like streaks under the nails, because they can signal endocarditis, where heart valve infections cause tiny emboli. And you also look for signs like clubbing or cyanosis, which may point to heart-related issues like heart failure or congenital heart disease, unlike respiratory-specific signs. What are xanthomata? Xanthomata are yellowish cholesterol deposits under the skin, often on tendons or elbows, indicating high lipid levels that increase cardiovascular disease risk, like atheroma. What? Guessing your next question. What other specific hand signs?
My next question is about capillary refill, actually. Why? What does capillary refill tell me?
Awesome. I'm still your patient in the cardiovascular OSCE, and you're checking the hands. Capillary refill time. Capillary refill time. Capillary refill time. Capillary
Get
refill
on
time.
with it, dude.
Haha. All right. I'm keeping it 100 as your patient. Capillary refill time tells you how well blood is circulating to the extremities. You press the nail bed until it turns white, release, and if it takes longer than 2 seconds to return to pink, it could indicate
And
poor
why don't I do it in the respiratory one too?
Still your patient here. You check capillary refill time in a cardiovascular exam because it directly assesses blood circulation and heart function, where delays over 2 seconds can signal heart failure or shock.
So,
but it's less.
Why do I also check brachial pulse in the cardiovascular but not in the respiratory?
As your patient in the cardiovascular OSCE, checking the brachial pulse is key because it gives a direct sense of the heart's pumping strength and rhythm, which can reveal cardiovascular issues like arrhythmias or weak cardiac output, not typically needed in a respiratory exam, where pulse checks focus more on rate via radial pulse to assess respiratory distress. You don't check the brachial pulse in the respiratory exam since respiratory issues primarily affect breathing, and radial pulse plus respiratory rate are enough to gauge distress without needing the brachial's cardiac-specific insights. Guessing your next question, what
And
other pulses?
why don't I check? Okay, where is the carotid pulse and where is the brachial pulse?
Still your patient in the cardiovascular OSCE. The carotid pulse is felt in the neck, just below the jaw, alongside the trachea, by pressing gently against the carotid artery. The brachial pulse is felt in the upper
Is it
arm.
close to the cervical chain lymph nodes?
As your patient in the cardiovascular
Fuck you now,
OSCE.
dude. You're not my patient anymore. We're not role playing. Now you're my teacher. Answer to me in a senses. Is the carotid pulse where the cervical chain lymph node is? Yes or no?
No.
Well, where is it? Lower, higher?
The carotid pulse is typically felt higher in the neck than the cervical chain lymph nodes. It's located just below the jaw, near the midline, alongside the trachea, while the cervical chain lymph nodes run lower, along the sternocleidomastoid muscle from jaw to collarbone. Guessing your next question, how do I avoid confusing the two when examining? If
My
so,
next question is brachial pulse. So is it closer? Is it medial? Is it closer to the thumb or to the pinky? And do I use two fingers?
the brachial pulse is felt on the inner side of the upper arm, halfway between the elbow and shoulder, closer to the thumb side, medial aspect, and yes, you use two fingers, index and middle, to press gently in the groove along the biceps. Guessing your next question.
Okay, so up to now, same introduction. I will just add to the hand check the xanthomata, and I will add to the hand check the xanthomata, and I will add splinter hemorrhages and the xanthomata, and I will take a capillary refill too. And I'm also going to take brachial and carotid pulse, and then I'm going to take the blood pressure. Let's go to the eyes. Same with for the mouth. With the eyes, I do the anemia, but I also check for xanthelasma and corneal arcus. What is this?
In the cardiovascular OSCE, you're adding xanthelasma and corneal arcus to the eye exam, alongside checking conjunctival pallor for anemia. Here's what they are in one sentence. Xanthelasma are yellowish cholesterol deposits around the eyelids, and corneal arcus is a grayish-white ring around the cornea, both indicating high cholesterol or cardiovascular risk.
Why do we call it xanthomata in the fingers and xanthelasma in the eyes? Can you give me the answer from a language, etymology, semantics, semiotics perspective? Hello?
Hello, you called me?
What you doing?
I was just in the car with my mum.
What you want to do now?
I don't know, maybe play some...
From a language etymology, semantics, and semiotics perspective, xanthoma, from Greek xanthos, meaning yellow, and oma, for tumor swelling, and xanthelasma, xanthos, plus elasma, for plate, describe yellowish cholesterol deposits.
Wait, sorry
Semant-
guys. My husband knocked my door. I've arranged to practice with him. Okay, sorry, tell me again the answer to the question between xanthelasma and xanthomata. Why xanthomata is in the thing? How does the name relate to the thing? structure and function, I guess, and location.
All right, no worries. Let's get back on track. From an etymology and semantics perspective, xanthoma, from Greek xanthos, yellow, and oma, tumor swelling, and xanthelasma, xanthos plus elasma, plate, describe yellowish cholesterol deposits, with xanthoma forming as nodular swellings on tendons or fingers due to lipid buildup, structurally linked to hyperlipidemia and cardiovascular risk, while xanthelasma appear as flat, plate-like patches around the eyelids, functionally
So what
indicating
is the
this.
elasma part, the elasma part and the omata part? What do they mean?
The oma in xanthoma comes from Greek, meaning tumor or swelling, describing the nodular raised cholesterol deposits on tendons or fingers, while elasma in xanthelasma, also Greek, means plate or flat patch, referring to the flat, plaque-like yellow lipid deposits around the eyelids.
Okay, and corneal arcus, what is that?
Corneal arcus, from Latin cornea, horn-like, referring to the eye's clear layer, and arcus, arc or ring, is a grayish-white ring around the cornea's edge, caused by lipid deposits, often linked to hypercholesterolemia and increased cardiovascular risk, especially in younger patients.
Okay, so for the cardiovascular examination, I'm gonna add a few things. For the hands, I'm gonna add capillary refill. I'm going to add the brachial pulse, the carotid pulse, and I'm going to add that I'm going to measure the blood pressure, and also that if there's splint hemorrhages. Remind me what splint hemorrhage is, and also the xanthomata, and then in the hands, in the eyes, I'm going to add the arcus, corneal arcus, and the xanthelasma.
All right, you're building a solid cardiovascular OSCEX, adding key checks for the hands and eyes, and you want a reminder on splinter hemorrhages. I think you meant splinter hemorrhages, not spleen hemorrhages. Here's the rundown on splinter hemorrhages, xanthoma, corneal arcus, and xanthelasma, plus confirmation of your exam plan in a concise response. Splinter hemorrhages. These are dark, splinter-like streaks under the nails caused by tiny blood clots or emboli, often linked to endocarditis, heart valve infection, or other vascular issues, visible during hand inspection. Xanthoma. Yellowish cholesterol nodules on tendons or fingers, indicating high lipids and cardiovascular risk, checked in the hand exam.
Okay.
Corneal.
Okay, so now my question will be the main part. We have the chest examination. So I have to check for any sternotomy, scars, other scars, and pacemakers. I can't observe any sternotomy, scars, chest wall scars, or pacemakers. I started palpating. How do I find the apex beat? It says mid-clavicular line. This is gonna be hard, dude. Mid-clavicular line, fifth intercostal space.
All right, you're diving into the chest examination for the cardiovascular OSCE, looking for the apex beat after checking for sternotomy scars, chest wall scars, and pacemakers, none observed. Here's how to find the apex beat, specifically at the mid-clavicular line, fifth intercostal space, in one sentence. To find the apex beat, palpate with your fingertips at the mid-clavicular line, an imaginary line straight down from the midpoint of the clavicle in the fifth intercostal space, the gap below the fifth rib, feeling for the heart's strongest pulsation, normally a gentle tap. Guessing your next question. How do I know if the apex beat is normal or displaced? If so, A normal apex beat is a localized tap at that spot. If it's shifted laterally or lower, it might suggest heart enlargement.
Shall I just pretend I'm palpating and just do it below the nipple?
Haha, I get the vibe, but let's keep it precise for your OSCE. Pretending to palpate below the nipple might get you in the ballpark, but the apex beat isn't always right there. It's specifically at the mid-clavicular line, a
But
vertical
I
line
can't.
from the
I'm
middle.
trying it on myself and I can't find. It's on my left hand side. I can't. I can't find it. So when I touch my clavicle and I go below my clavicle, which rib is that?
No worries. It can be tricky to find the apex beat, especially on yourself. The apex beat is on your left side, since the heart is mostly on the left, specifically at the mid-clavicular line in the fifth intercostal space. And here's how to locate it. Start at your clavicle, collarbone, on the left. The first rib is just below the clavicle, but it's partly covered by the bone. Count the ribs downward. The second rib is at the sternal angle, where the manubrium meets the sternum. Then count to the third, fourth, and fifth ribs. The fifth intercostal space is the gap just below the fifth rib. The mid-clavicular line is an imaginary line straight down from the midpoint of your clavicle, halfway between the sternum and the shoulder. Palpate with your fingertips in that spot, left of the sternum, feeling for a gentle
So
tap.
annoying. On my right hand side, I can't do this. On my other side, I can't.
Haha, I feel your frustration. It's tough finding the apex beat, especially on yourself. Since you're trying on your own body, let's simplify it for your left side, the heart side, not your right hand side.
Wait.
Find
second.
your left
I'm on the second one. Wait. The second one. Gap. Third one. Gap. Third
All
one.
right. I hear you.
Wait. Third one, guys. I'm on the third one. Third mid-clavicular gap. Fourth. Okay, I'm on the fourth rib. Gap. Kind of on the fifth rib.
All right, let's lock this in for you. You're trying to find the apex beat, and you're focusing on the mid-clavicular line, aiming for the gap below the fourth rib, which is the fourth intercostal space, just above the fifth rib. Here's how to find it in one clear sentence. To locate the apex beat, place your fingertips on your left side along the mid-clavicular line, straight down from the middle of your left clavicle, in the fourth intercostal space, the gap just below the fourth rib, above the fifth rib, and feel for a gentle pulsation. Guessing your next question, why is it hard to feel the apex beat sometimes? If so, it can be subtle, especially if you're healthy, overweight, or not leaning forward. Try exhaling fully or pressing lightly to feel it better. What's next? Or still struggling with finding it?
Well, I'm trying to palpate. So, clavicle, rib number 1.
All right, you're still working on palpating the apex beat, starting at the clavicle to find that mid-clavicular line and the right spot. Since you're
Is
focusing
there
on
like
the
a technique
clavicle,
I could use?
to palpate the apex beat, use your right hand's fingertips to press gently along the left mid-clavicular line in the fifth intercostal space, below the fourth rib, leaning the patient forward or asking them to exhale to make the heart's pulsation easier to feel.
So I hope it's a man that I'm gonna examine.
Haha, I hear you, hoping for a man to make the exam easier, maybe fewer curves to navigate. For finding the apex beat, the technique is the same regardless of gender. Place your right hand's fingertips on the left
guys, I need to
mid-clav.
watch a video of it. Okay, so I'm gonna check his dorsalis pedis and posterior tibial arteries. How exactly do I do that? What are these?
Alright, you're moving to check the dorsalis pedis and posterior tibial arteries and the cardiovascular ossi, which are key pulses to assess peripheral circulation. Here's how to do it and what they are in 2 sentences. The dorsalis pedis artery is on the top of the foot, felt by pressing gently with 2 fingers, index and middle, just lateral to the big toes extensor tendon, and the posterior tibial artery is behind the inner ankle, felt by pressing just below and behind the medial malleolus, ankle bone.
Why do I check for these ones specifically?
You check the dorsalis pedis and posterior tibial arteries specifically because they are key peripheral pulses that reveal the health of blood flow to the lower limbs, helping detect peripheral artery disease or reduced cardiac output in cardiovascular disease.
So how do I check for left parasternal area for heaves?
To check for left parasternal heaves, place the heel of your right hand firmly on the patient's left parasternal area, just to the left of the sternum, around the 3rd to 5th intercostal spaces, and feel for a sustained, forceful lift during systole, which indicates right ventricular hypertrophy or overload.
Okay. And how do I check for thrills?
To check for thrills, place your fingertips or the heel of your hand over the 4 cardiac valve areas, aortic, pulmonic, tricuspid, and mitral, on the chest and feel for a palpable vibration, like a cat purring, which indicates turbulent blood flow from conditions like valve stenosis.
How do I do this? I don't know how to place this there.
To check for thrills, gently place your fingertips or the heel of your hand over each of the
What
4
is the heel of my hand?
The heel of your hand is the firm, fleshy part at the base of your palm, just above the wrist, used to check for thrills by pressing it gently over the 4 cardiac valve areas. Aortic, pulmonic.
I only know the cardiac valves inside the heart. I don't know it outside.
No worries, let's clear it up. The 4 cardiac valve areas on the chest, outside the body, where you check for thrills, correspond to where heart sounds from the valves are best felt or heard, not their exact internal locations. Here's how to find them in 1 sentence. Place the heel of your hand over the aortic area, right 2nd intercostal space near the sternum. Pulmonic area, left 2nd intercostal space near the sternum. Tricuspid area, left lower sternal border, 4th, 5th intercostal space. And mitral area, left 5th intercostal space, mid-clavicular line.
Okay, wait, I'm very confused. So, I check for heaves in around the 3rd intercostal space, and then I check for heaves and thrills, and then I auscultate the mitral area first using bell. What is bell? Then I use the diaphragm. How do I do that? And then I check the aortic, pulmonary, and tricuspid areas. But where are these? Yeah. I ask a patient to sit up and listen to the bases of the lungs, posterior chest, and then I check for sacral edema for 2 seconds, and I see if there's any pitting. And then I check for peripheral edema at the ankles by pressing over the lateral malleoli and looking for pitting. I don't understand this language, brother.
All right, brother, I hear you. Let's simplify this cardiovascular Aussie chest exam and break down your confusion step by step, addressing heaves, thrills, auscultation, Belvy's diaphragm, valve areas.
Yeah, and do it as effectively and efficiently as possible, saying the least amount of words to get our point across.
Heaves, feel heel of hand, left parasternal, third, fifth intercostal for forceful lift, right ventricle overload. Thrills, press heel, aortic, right second intercostal, pulmonic, left second intercostal, tricuspid, left lower sternum, mitral, left fifth intercostal, midclavicular.
Wait, okay, sorry, heaves, okay, thrills?
No prob. Heaves, press heel of hand on left parasternal area, third, fifth intercostal space, for a sustained lift, indicating right ventricular overload. Thrills, feel with heel of hand over aortic, right second intercostal, pulmonic, left second intercostal, tricuspid, left lower sternum, and mitral, left fifth intercostal, midclavicular.
Wait, so left and right set intercostal, and what else?
For thrills, press the heel of your hand over the aortic, right second intercostal space, near sternum. Pulmonic, left second intercostal space, near sternum. Tricuspid, left lower sternum, fourth, fifth intercostal space. And mitral, left fifth intercostal space, midclavicular line.
Wait, left and right fifth, you said?
My bad for the mix-up. For thrills, you check the aortic, right second intercostal space, near sternum. Pulmonic, left second intercostal space, near sternum. Tricuspid, left lower sternum, fourth, fifth intercostal space. And mitral, left fifth intercostal space, midclavicular line. Areas with the heel of your hand for vibrations. No left or right fifth intercostal spaces are involved for thrills. Guessing your next question.
Wait, didn't you say around fourth, fifth intercostal I will check the last two valves just now?
Got it. Let's clarify. For thrills, you check the tricuspid area, left lower sternum, around fourth, fifth intercostal space, and mitral area, left fifth intercostal space, midclavicular line.
So right and left.
All right, let's straighten it out. For thrills, you check the aortic area, right second intercostal space, near sternum. Pulmonic area, left second intercostal space, near sternum. Tricuspid area, left lower sternum, fourth, fifth intercostal space, and mitral area, left fifth intercostal space, midclavicular line.
I'm so confused.
No worries. Let's simplify this. For thrills in the cardiovascular exam, you use the heel of your hand to feel for vibrations at 4 spots. Aortic, right second intercostal space, near sternum. Pulmonic, left second intercostal space, near sternum. Tricuspid, left lower sternum, around fourth, fifth intercostal space. And mitral, left fifth intercostal space, midclavicular line. The right and left second intercostal spaces are just for aortic.
Bro, sorry, I'm confused. Tell me again.
All right, let's make it crystal clear. To check for thrills, use the heel of your hand to feel for vibrations at.
Okay,
aortic.
I know, I understand. So, it's, I know, so it's, I remember the second and the fourth and the fifth. I just don't know, when you say parasternal left, is the location that's the problem. I understand the x-axis, it's the y-axis that's the problem.
Got it. You're good with the intercostal spaces, x-axis, like second, fourth, fifth, but confused about the parasternal left and other locations. Y-axis, the horizontal placement. Let's clarify the y-axis for checking thrills in one sentence. For thrills, feel with the heel of your hand at the aortic area, right of sternum, second intercostal. Pulmonic, left of sternum, second intercostal. Tricuspid, left lower sternum, fourth, fifth intercostal. And mitral, mid-clavicular line, fifth intercostal, roughly below the left nipple. Guessing your next question?
But so it's gonna be it's gonna be the left side is gonna be more laterally, the right side of the sternum. My hand is gonna be more medially because the heart is on the left, yes or no?
Yes.
How much to the left, how much to the right?
For thrills, on the right side of the sternum, aortic area, second intercostal space, your hand is placed close to the sternum, about 1-2 centimeter medial. On the left side, the pulmonic area, second intercostal, is just left of the sternum, 1-2 centimeters. Tricuspid, fourth, fifth intercostal, is along the left sternal border, 0-1 centimeter from sternum. And mitral, fifth intercostal, is further left at the midclavicular line, about 7 to 10 centimeters from the sternum.
Alright, and then we have the auscultation. I assume it's the same areas that I'm going to check. So what does the diaphragm have to do with it, and what is this using bell for mitral area?
Yes, for auscultation, you listen over the same 4 cardiac valve areas as thrills. Aortic, right second intercostal space, near sternum. Pulmonic, left second intercostal space, near sternum. Tricuspid, left lower sternum, fourth, fifth intercostal.
You know this thing they do with their hands, like they put the hand and then they do it 90 degrees anti-clockwise, and then they do it again 90 degrees clockwise, and it's like moving the hand across the chest. What is this? Does this have to do with finding the valves?
You're describing a technique some clinicians use during auscultation, where they place the stethoscope, rotate it 90 degrees counterclockwise, then 90 degrees clockwise, moving across the chest to optimize hearing heart sounds from the cardiac.
The hand.
Got it. You're talking about the hand movement, where clinicians place their hand on the chest, rotate it 90 degrees counterclockwise, then 90 degrees clockwise during auscultation. This is part of a systematic auscultation technique to position the stethoscope precisely over the cardiac valve areas, aortic, pulmonic, tricuspid, mitral.
So where the fingers are, I measure, and then I measure. I see. So I measure where the fingers are, where the heel is, then I bring the fingers 90 degrees up, I measure where the fingers are, and then I bring the heel up and 90 degrees, and I measure there again, yes?
Yes, you're on the right track. During auscultation, you place the stethoscope with your fingers holding it over a valve area, e.g. aortic, right second intercostal space. Rotate your hand 90 degrees counterclockwise to listen, then 90 degrees clockwise, keeping the heel of the stethoscope in place as a pivot to capture heart sounds from slightly different angles in that spot before moving to the next valve area.
Okay, we
So you're at the chest
talked
part of
about
the
the
cardiovascular.
thrills, we talked about the heaves, we've talked about auscultation using this hand method. How do I check for sacral and peripheral edema?
Okay, so we're diving into checking for sacral and peripheral edema in the cardiovascular exam. For sacral edema, have the patient lie flat or sit up if they can't lie down comfortably. Gently press your fingers over the sacrum, that bony area at the base of the spine, for a few seconds. Look for pitting, where the skin stays indented after you release pressure.
What
It's
is this? I don't know this.
No worries. Let's break it down. Peripheral edema means swelling in the extremities, usually the legs, ankles, or feet, caused by fluid buildup. It's often a clue to heart issues, like heart failure, where the heart isn't pumping well enough, causing fluid to pool. To check
How
it,
do, so I have to check for sacral edema for 2 seconds. Hey guys, I apologize for the abrupt ending of this episode. I'm recording this afterwards. Yeah, this is not going to be the usual occurrence. I hope you have a good day.